today to be able to give you an introduction to the modern general practice approach that's been described in the delivery plan for recovering access to primary care that was published in May, and share some of the key findings from our research, looking at a modern general practice approach before talking about the National General Practice Improvement Support Programme and how we can support and help practices and PCNs to go on this journey. Could we go to the first slide, please? Oh, something's just happened to my screen now, so I'm going to have some technical issues.
We can see you though, Minal. I can see you and the slides.
Okay, great. Yes,
I can. The first one now.
I didn't see the slides. I want to just start off by sharing why this work matters to me. So I've been a GP in Harleston for over 10 years. And if you don't know Harleston, it's one of the most deprived areas in the country. Most of my patients have not completed education, they are not in training, and those in employment are on 0-hour contracts or working low-income jobs. We've had one of the highest mortality rates from COVID, and our prevalence of long-term conditions like diabetes, heart disease, cancer, mental health are significantly higher than the national average. And a few years ago, as a practice, we were in crisis. In fact, we were at sustained crisis point. Staff were unhappy, receiving constant abuse. Clinicians were stressed all the time. Patients were unhappy as our appointment times exceeded 6 weeks. And it was typically those with the sharpest elbows getting through every week. And it was taking a personal toll on all staff. You know, personally for me, I have young children and I was missing out on seeing my children most evenings. And that really felt unsustainable. So as a practice, we had to change our way of working. And we moved then to a modern general practice model. And I would never go back. Our wait times have gone down from 6 weeks to 2 days. Our continuity levels have significantly improved. Patient complaints are down. Staff are much happier. And I personally feel more in control of my working day. And really importantly, we feel safer. We're picking up urgent presentations that may have typically waited weeks in a first come, first serve model the same day. And it goes without saying that we are still very busy, but our working lives are much, much more manageable. So this is not a magic bullet, but it does definitely feel like we've got our heads back above water, can actually start to think about the future. That's something we were never able to do before. We couldn't even think 6 months ahead. And that's really helped us now think about how we want to evolve as part of our PCN and as part of integrated neighbourhood services and proactively explore the opportunities ahead of us. But being at crisis point is horrible, and making change while you're at crisis point is even harder. We made the changes at the time without any support, funding or shared resources. We really didn't know what the answer was. We used a lot of energy in trying out different tools and different approaches. And this is why I am really excited about the National General Practice Improvement Programme, why it is really important to me, because perhaps for the first time ever, there is centralised support for practices and PCNs on a systematic basis. There is alignment of funding, incentives and priorities. There's investment in better quality digital tools and a commitment to a national comms campaign so we can deliver meaningful change that's relevant to our current challenges with funded support to adapt this to our local contexts, ideally before we get to sustained crisis point. Could we go on to the next slide, please? So as a primary care transformation team, we lead the National General Practice Improvement Programme. We are clinically led. We have a team that is deeply rooted in general practice. I have a faculty of GPs, practice managers, nurses, other clinicians who have extensive experience in improvement. We work with delivery partners who have delivered over 40,000 improvement sessions with general practice teams. We work with a brilliant network of digital clinical primary care leads. We are evidence-driven and we take a ground-up approach. Those closest to the problem are best placed to find the solutions. We know that. There's an abundance of evidence that tells us that. And what we have done is we have evaluated and codified the amazing work that practices have been doing to tackle their challenges and have developed a program of support to share that learning, make the process of doing the change easier, and therefore help practices and PCNs enable them to realise the benefits faster, essentially de-risking the change. And we're also driving the evidence base to inform the development of highly usable and accessible digital tools with the right functionality to support general practice transformation. Could we go on to the next slide, please? So what are the problems with the current model, or the traditional model, I should say? So we know that the traditional model of general practice isn't working for patients or staff, and this is almost universal. So patient satisfaction with their contacting their general practice has fallen in the majority of practices, so over 85% of practices. And we have fewer GPs providing care for more patients. So on average, practices are managing 17% more patients than they were 8 years ago. And so I think it's quite remarkable that despite these challenges, patient experience or satisfaction with the care they receive from their general practice teams remains high. And I think that's a real testament to my colleagues. We know how hard general practice is working, delivering more than 1 million appointments per day. And it's one of the few parts of the NHS delivering more activity than it was pre-pandemic. Demand has gone up by about 15%, and that's clinical consultations. We think that there is, as an estimate, 30 to 50% increase in indirect patient-facing workload. And this is not just a COVID effect. It's projected to continue to increase, and it's mostly driven by an aging population. So our population will grow by about 3.4 million in the next 10 to 15 years. And that growth is almost all in the over 70s. So while it's fantastic, we're living longer, and that's absolutely something to be celebrated, the age of onset of ill health or major ill health hasn't changed. So we'll be living longer, but with multimorbidity. And we know patients over the age of 70 require primary care services at least 5 times more than younger patients. So this will continue to put pressure on general practice and primary care. We also know that GP capacity is falling. We've seen a 3.3% reduction in full-time equivalent GPs since 2019. And the main reasons cited are stress, burnout, and workload. And I don't think that will come as a surprise to anyone. Over the last 15 years, we've had a quarter of practices close and a fall in the number of GP partners. And I think while we're all feeling the pressure, it's fair to say that practices working in the most deprived areas are more strongly impacted. We can see that they're managing about 1,000 patients or more per GP partner when we compare them to affluent areas. And what we can also see from the data is that their ability to stretch to meet the rising demand is slowing down, and therefore sustainability is at risk. And so the emotions that I'm sure we will all recognise that our patients are feeling are ones of confusion. You know, things have changed rapidly over the last couple of years during the pandemic, and they're not sure how it works. Frustration with the 8 a.m. rush and being told to call back the next day. Worry about whether they'll get an appointment when they need one, and a feeling that the service is unfair based on first come, first serve, fastest finger first, allocation of appointments. And similarly, from a practice perspective, the current model means that staff feel like they're carrying increasing clinical risk as demand and complexity rises, that if we're not able to see all our demand, it becomes very difficult to plan our work as effectively as we'd like. And if we're not able to understand patient needs fully at the point of contact, then it becomes difficult to be able to prioritise care safely, easily, based on need. So what this means is that we need both more workforce, clinical and non-clinical, so GPs, nurses, management support, and now we need to absolutely maintain a critical focus and investment on recruitment and retention. But we also need to make the best use of our workforce and have a model that supports general practice to be fairer, safer, and more sustainable. Can we go to the next slide, please? So what does that look like? Well, firstly, I think it's important to say that it's not a new model. Most practices are already doing some or all elements of this, and it's building on this fantastic work and codifying it so we can spread the learning and support offers and adapt locally. This really is ground up. Secondly, it's about making each of the steps in the process more rigorous so that we can get the most benefit out of them. And it's about the process and the process change rather than the technology. So we need to make the changes to our processes, which then technology can help us enhance rather than the other way around. And thirdly, it's about knitting all of the elements together for biggest impact. So the objectives are to be able to see and understand all express demand and plan, to reduce avoidable appointments and support safer, more equitable allocation of capacity, and make full use of the multi-professional team and improve our working environment. And so to do this, we need parity across access channels so patients can use them flexibly. We don't want to exclude anyone. We know there is no one size fits all. But we also need consistency of process regardless of how you access. And from a practice staff perspective, a single workflow is much easier to teach and manage than juggling multiple different processes. It's about using data from digital systems, whether they be our telephony systems or our online consultation systems, to help us understand demand patterns and plan our workload more effectively. And that helps gain back some control over our working day. So we can spread non-same day demand across the week. We're not booking planned care or meetings at the times that we're likely to be most pressured. And it's about helping us adapt rotas to better match peaks in demand. And then it's about improving the quality of the online journey. So the usability and the accessibility of the digital tools and the communications and the expectations about how these work, so that we can start to shift more patients to online channels where appropriate, to free up phone lines for those that can't or don't want to use digital and flatten that 8 a.m. peak. It's about collecting structured information up front to really filter out the work that needs general practice and what doesn't, and then really use our multi-professional team to best effect. So it's supporting navigation, assessing risk and prioritising. So we can use this information to filter out admin tasks or where patients could self-serve, for example, ordering their repeat prescriptions. They can do this online in lots of cases. And again, this is supported by actions in the recovery plan to widen the range of self-referral services and improve the quality of digital pathways, particularly for key transactional tasks. It's about embedding consistent use of signposting and navigation to maximise use of capacity within the team. So particularly the use of community pharmacy, which again is supported by an investment in the expansion of community pharmacy clinical services, in particular the management of low acuity but high volume demand. So things like sore throats, earaches, sinusitis. It's about helping teams understand the skills of the multidisciplinary team to then encourage top of band working, optimizing the use of GP time for where it adds most value, prioritizing care based on need to provide care more equitably and safely, enhancing continuity of care for those that need it, enabling more efficient ways of responding. So by having more information up front, it increases the chances of remote closure with the message or choosing the right consultation modality first time. And by unlocking flexibility in our appointment book and reducing avoidable appointments and duplication, we're able to claw back precious time to reinvest where it's needed. And that might just be going home earlier or having a break or spending more time with patients with more complex needs. And it's then about underpinning this with technology. So having the right tools to enhance the benefits. So that's thinking about cloud-based telephony, online consultation systems, messaging tools, and appointment self-booking tools in particular to reduce burden on staff and provide a better experience for patients. Now, many practices will be in different places. And for some, it will make sense to make these improvements incrementally, and for others, they may choose to go big bang. Either way, the benefits of improvement at each of these steps are cumulative. If we could go to the next slide, please. And so here are some examples of the value that can be created. So the ELITE programme is a programme that runs in the southeast region, and it analysed almost 57,000 general practice appointments. And what they found was there was an opportunity to potentially avoid 16% of appointments. And so they've been doing lots of work with their practices. And in the first phase, they've managed to release on average 2.5% of GP appointments and 3.1% of nursing time. Now, this is an ongoing piece of work, and this was just phase 1. I think the other thing to probably highlight is the referral to community pharmacy. So many of us, in fact, the majority of us have made at least one referral to community pharmacy. So over 4,500 practices have made a referral. And between April 22 and February 2023, that equated to over 450,000 referrals. And really important to highlight, only 6% of these referrals were escalated back to general practice. So again, you know, they provide a fantastic resource for us as teams. I think it's important to call out continuity of care. So we all know about the value that continuity of care brings. But this is a more recent study that has shown that by improving continuity of care, we can actually reduce demand. So it reduces the duration between appointments when patients see the same clinician or doctor they've seen most frequently over the last 2 years. And that's estimated to lead to a 5.2% reduction in consultation numbers. Unsurprisingly, the benefit is largest for older patients, those with multiple chronic conditions and mental health conditions. We have done a large study looking at the modern general practice model, which I'll come to in a minute, but particularly we've looked at patient experience. And what we find is that where practices have implemented this model, patient experience, when they use the right digital tools, the high quality digital tools that are usable and accessible, improves by 6 percentage points compared to the national average. And then, sorry, my computer is also playing up a little bit. Upgrading to cloud-based telephony. So an NHS cloud-based telephony pilot covering practices, covering a population of over 1 million patients. Staff in those practices, majority, so over 90%, would recommend the change, particularly because they felt it reduced burden and improved their working lives. 60% agreed the number of complaints about getting through on the phone reduced, and 70% agreed that it made it easier to manage their workload. So I think it's really important to recognise that all of these steps can add value, but when they're knitted together, the impact can be really large. If we could go to the next slide, please. So I mentioned that we had carried out a large evaluation. So we've been working with the Health Foundation and the Improvement Analytics Unit. And we carried out a study to look at the impact of the modern general practice access model. I should update the figures on this slide because it's now 154 practices that we looked at, and it covers 10 million patient contacts. And as you can see, we carried out the research between March 19 and actually February 2022. And we looked at practices that were using this modern general practice, had implemented this modern general practice access model, and they were using a particular online consultation system called Ask My GP. And for those that are unfamiliar with Ask My GP, it is a short, structured questionnaire that allows patients to respond using free text and then submit their request to their practice. It also has a workflow system inbuilt that the practice can then use to triage and navigate the request to the right member of the team, and also can use it to respond to patients through messaging, otherwise alternatively a telephone or a face-to-face. And one of the things the system does is it collects lots of data, which is why this is a really powerful evaluation, because it's given us access to data that we wouldn't traditionally have been able to analyse. So could we go to the next slide, please? So I think the first thing to say is that in these practices, on average, there was a channel shift. So 70% of patients were accessing the practice online, with 30% through more traditional routes. And what they found, or what we found, was that having used the online route, patients were more likely to do so next time, but they used the online routes flexibly and dynamically. So patients were more likely to choose telephone or in-person access for new problems or issues that they perceived were likely to be more urgent, whereas requests initiated online tended to be from patients asking about existing problems, female patients, younger patients, so particularly those under 45, and for those with a preference for an online message response. Really interestingly, there were no differences in these trends before and after, or before and during the pandemic. If we could go to the next slide, please. Sorry, I should just say with the previous slide, before the pandemic, sorry, could we go back a slide? Before the pandemic, because I think this is an important point to make, in these practices, they saw an increase in the proportion of requests made online that did not increase in line with demand. So actually suggesting a genuine channel shift in behaviours from telephone or in-person contact to online access. During the pandemic, there was no increase in the ratio of requests made online versus telephone, suggesting that the ability to contact the practice online was not stimulating the additional demand. And when we looked at demand patterns, we could see that some of that additional demand was being driven by the COVID backlog, and particularly where we had seen a dip in certain types of patient requests, those recovering. But I think this helps from a data perspective confirm a shift in behaviour, so patients channel shifting from online, from traditional routes to online. And there was no evidence in this study, which was a big study, of supply-induced demand fueled by easier access. Could we go to the next slide, please? The study does show that there was increased workload pressure on general practice. So I don't think that comes as a surprise to any of us. But there's significantly greater volumes of demand that were coming from the older age groups. Now, this is an important finding because in the analysis, older people were the cohort that was least likely to go online and use the digital system. So actually, by implementing the system inclusively, it benefited both digital and non-digital users. So our non-digital users were not disadvantaged by this new model. Could we go to the next slide, please? I think it's also really important to bust a very common myth that everybody wants face-to-face care. So when we looked again at the requests for face-to-face versus online message or telephone, only a minority of requests at these practices indicated a preference for face-to-face consultation. Actually, there was variation in care delivery across different patient subgroups, and that suggests that clinicians were tailoring care according to patient characteristics, clinical risk, and their preference. So most patients preferred to have a telephone call. The second most common option was online message, and face-to-face was only 12%. Could we go to the next slide? And I think really importantly to highlight, the mode of contact did not determine how care was delivered. So face-to-face consultations were more likely to be used by clinicians for the youngest and eldest patients, those asking about new medical problems, non-frequent attenders, so people that were not familiar to the practice, those asking for a preference for continuity of care, so suggesting perhaps more complexity of need, and a preference for a face-to-face consultation. Patients with existing problems, more frequent attenders, were more likely to have a remote consultation. And that's partly because these patients are less likely to need a physical examination. They're more likely to be known to their general practice and have a pre-existing relationship or doctor-patient relationship. Similarly, if we could go to the next slide, please. Practices were prioritising responses based on clinical needs. So again, the more vulnerable groups, new presentations received a response faster, although overall practices were able to provide a very responsive service to their patients. Could we go to the next slide, please? However, this is complex adaptive change. And traditionally, the way the NHS has managed complex change, particularly in primary care, is through an over-reliance on contract and micro incentives. But what we need to be successful here is commitment, not compliance. And so I think this is why the recovery plan is really is very exciting, because it starts to build the foundations for focusing investment in leadership, culture, capability, peer learning and improvement through the National General Practice Improvement Programme. And again, this is echoed in Claire Fuller's stock take as well. And this is a review that was done by the King's Fund, which again just reiterates that changes work best when they're driven from the bottom up. And the soft stuff, the critical enablers that we just talked about, are really, really important. Can we go to the next slide, please? So what is the support offer to help practices and PCNs? So what's the General Practice Improvement Programme? So it's a 2-year programme, and it aims to do 3 key things. So it aims to support improvement. So it aims to make change, the process of change easier and the realisation of benefits faster by supporting practices and PCNs to make the change. I'll come on to that in more detail in a second. It provides support for building capability and skills in-house, so in our teams, in the NHS, to drive and sustain change. And it aims to create active learning systems, so both national and local peer communities for sharing challenges and learning with the ICS. And we know that social networks, peer networks, are the most powerful way for a spread and scale of innovation. And so I think it's really important to make that point. If we could go to the next slide, please. So what's the support offer to help practices and PCNs? So there's a tiered support offer, because we recognise there is no single size fits all. So there are 3 tiers of support. There's a universal offer that's open to all practices and PCNs. This is a combination of online resources, so good practice, self-facilitation activities, webinar series, and then interactive drop-in sessions to support people. And that's linked to high quality tools to help them make some of those changes. And I'll come on at the end to a link to our webpage where you can find links to webinar dates and resources, etc. And we will continue to improve and iterate these as we learn. There's an intermediate offer, which is available at either practice or PCN level. So it's 3 months of hands-on facilitated support. And then we have an intensive offer, and this is particularly targeted to practices that are working in the most challenging circumstances, to give them 6 months of hands-on facilitated support at a practice level. Now, for the hands-on support, ICBs need to nominate practices to our national programme. So we're working very closely with regional ICB teams, and we have a regional team. We have our own team that we are distributing to regions to support that can support ICBs in this process. But as part of this, it's really important that ICBs can understand the support that's needed. And so what we have developed is a tool called a support level framework. And what it does is it helps practices and PCNs understand what they do well and where they want to focus on in terms of their development. It also helps ICBs understand the wider support needs. And it's not a self-assessment tool. It's not a tick box. It's a facilitated conversation, because that really helps build that shared understanding and those relationships that are critical to the transformation that we're talking about. And it can then help PCNs and practices build a clearer and a more shared common vision for a multidisciplinary model of care that can be co-designed with their communities. And it really helps translate some of that policy into what does it mean for me? What does it mean for my local population? It also means there's a much more transparent and consistent way of ensuring practices that would most benefit from support receive it. In terms of content, it focuses on 5 key areas. So we have identified the key areas to focus efforts on, particularly over on activities that matter most, and to make the changes faster and more easily. So we've codified this content. And so they are care, understanding demand and capacity, care navigation and triage, the telephone contact journey, the patient online contact journey, and then thinking about wider workload management, that kind of holistic approach, so that we can absolutely use our roles and our staff to best effect and reduce burden wherever we can. And so what are the outcomes we're trying to achieve? Well, ultimately, we're trying to improve staff and patient experience. We want to reduce avoidable appointments and unnecessary work and variation, what we would call failure demand, improve continuity of care. And we will measure this through a basket of measures, or what we've called improvement indicators. So looking at patient satisfaction, staff experience measures, an avoidable appointments audit, which also picks up where continuity could be improved, looking at online consultation submission rates, telephony data, as well as the use of CPCS, recognising there is not going to be a single indicator that tells us everything, because this is a complex change. If we could go to the next slide, please. So just want to talk briefly about the skills, training and learning communities that I mentioned. So there is nationally funded care navigation training available to practice and PCN staff. There are 2 offers available, depending on the maturity of the care navigation skills within the practice or the PCN. We then have a fundamentals of change and improvement training program. This is for all staff, clinical or non-clinical staff. It's an accredited QI program, which really focuses on embedding some of the key skills and quality improvement into teams to start building that capability to tackle local challenges. We have a bespoke digital and transformation leads training program, which I think I might have mentioned the last time I was here. So it's a development program that includes core teaching modules, one-to-one coaching, and also working alongside our improvement team, so learning by doing, to help build some of those practical skills for leading change, making effective use of data and digital technology, and also building those relationships to work collaboratively, and that particularly skills in facilitation that are so key to then engage with stakeholders. And we then also have a general practice improvement leadership program, again, an accredited QI leadership program. And we're asking ICBs to find local peer ambassadors, those that fly the flag for QI locally, to nominate them to our leadership program, where we can provide them with additional training and support, but then with the kind of promise to re-embed them into local structures so they can help support other peers, and they can help drive some of those local communities of practice. Could we go to the next slide, please? So, why should my practice or PCN take part? Well, first of all, we have worked with hundreds, if not thousands actually, of practices previously on improvement initiatives. And what we find is that while practices are very different in terms of their demographics, typically they all focus on 4 key needs: managing demand, improving patient experience of access, developing their teams, and job satisfaction. And that is what the focus of this programme. It helps to create headspace, capability, and a culture for practice staff to innovate and take action. It provides a flexible offer to meet different needs of different practices. It's taking shared learning, and it's offering practices faster, proven routes to improvement and quick wins. The cost of transformation is supported. It offers access to primary care improvement expertise. It builds on good foundations, so the Accelerate programme and the Time for Care programmes that you might have heard of before. And it particularly prioritises support to practices with the greater sustainability challenge. And I think that's really important if we want to tackle health inequalities. If we could go to the next slide, please. Now, apologies, this is quite a busy slide, but I'm going to try and take us through this quite quickly. So there are different types of funding available to ICBs, to PCNs and practices that can support general practice, whether it's practice or PCN, to make the changes in line with what we've just been discussing. And I put it on a slide because I think it can feel quite complicated. So it's trying to bring it all together. So there is the IIF, National Capacity and Access Support Payment. This is paid to PCNs, roughly 11,500 per PCN per month. And this is unconditional funding, but it's there to support things like backfill, or however PCNs and their member practices want to use it to help them progress some of this work. There is also the IIF improvement payment, and that is paid at the end of the year based on what has been agreed locally between the ICB and the PCN and what they've achieved. And that equates to roughly 56,000 per PCN per year. There is then the primary care service or system development funding, so what we call primary care SDF funding, and that's given to ICBs to support transformation programs. So that can be to provide local support to practices and PCNs that need additional or ongoing support, wider support, for example, and a wider range of tools, for example, business intelligence tools that can support with data. And so that again is a local decision based on local need. And then there is transition cover and transformation support funding. And so that's the practices that are coming towards kind of going live with a new model or modern model. So doing that transition in model. And that on average is about 13,500 per practice, and it's available to provide additional capacity to help smooth the transition to a new model. So we hear a lot from practices that have done this, about the importance of clearing the backlog. And so this can be used to, help practices start from a clean slate. And that could be support from experienced peers, additional sessions, clinical or non-clinical staff. And that again is distributed by the ICB to practices. There is also additional funding of training and enablers and support. So as I talked about before, we need the right technology to help us underpin this. So there is funding to help move practices from analog telephony systems to cloud-based telephony systems, funding to support higher quality digital tools, online consultation messaging and appointment booking tools. We've done a lot of user research on what good looks like from a patient perspective, as well as from a staff perspective. We'll be publishing that hopefully in the next few weeks. And that evidence has been used to set out the key requirements and capabilities as part of a new framework that's being launched in August. Care Navigator training, as I mentioned, and then of course the National General Practice Improvement Programme. And I think it's really important to say that communication is going to be absolutely key to this. We need to take people along with us. We need to take the public along with us. And so there is a commitment in the plan of funding a communications campaign to really help explain the why. So why these changes are happening, what the new model means, and what people can expect. And I think that will be absolutely critical as we move forwards. Could we go to the next slide, please? So just a kind of final slide on if you want to find out more, links to the programme, how to access the support. It's all on that link at the bottom of the slide. And of course, you can contact us if you have any further questions or queries. I think the one thing I would like to emphasise that perhaps is not really clear in these slides is that we are working at every organisational level. So we are also working with systems to help build their capability in the improvement and transformation space. And some of the faculty members that I mentioned earlier on, GPs and practice managers with this vast expertise in improvement, but also understanding what the kind of primary care context on the ground looks and feels like. We're embedding them via regions into ICBs to help build and accelerate some of that maturity to drive this forwards, because they are absolutely key, critical leaders in driving improvement and transformation going forwards. I'm going to stop there.
Brilliant. Thank you very much, Minal. That was great. I think there's a few questions come up in the chat. So let's see, Bimel's asked about any transition funding guidance not out until next week at least.
Yes, it's going to be published next week, but regional colleagues will have had a copy. So, speak to your regional colleagues if you want more information, but it will be published next week. When
you say regional, is that the ICB or the regional teams?
The regional teams, so the regional primary care teams, for example, and regional finance colleagues.
Brilliant, thank you. Then somebody said, what process do you use? What process do you use to measure changes in patient satisfaction when implementing change at this level?
So we're not collecting new data on patient satisfaction because it's really important to get the balance right in terms of kind of burden of data collection versus actually the improvement work. So we're using, national GPPS patient survey. We have in my practice also the friends and family tests. We collect feedback from our PPG. Practices and PCNs will be collecting lots of local information as well. So it's just bringing together different data sources that are available locally to understand that picture. We're not doing a new data collection on patient experience.
Okay. John, have I missed anything else on the chat? There's a couple of things coming in. Oh, John's on mute.
I'm unmuted. Sorry, apologies. Standard mistake. Yes, Kieran has said, any thoughts around a balanced scorecard type approach for the data?
Yeah, I think a balanced scorecard is always really important. I think you need kind of you need the balancing metrics to understand. So we have a kind of detailed set of improvement indicators that we look at, and we are working with analysts and the Improvement Health Foundation and the Improvement Analytics Unit at the moment, really trying to understand what's most helpful to look at. We're doing a kind of wider piece of work, I think, just beyond the general practice improvement programme, looking at Sentinel improvement measures, and we're working with a whole range of stakeholders, looking at what is critical when we're thinking about improvement in primary care. And that takes us to some, really interesting questions like, what does quality look like? How would we describe quality? How do you measure integration? How do you measure continuity of care in a world of multidisciplinary working? So there are some really important key questions that we're working through there. But I also think it's worth thinking about there are enabling measures, and then there are also kind of what you would call perhaps disabling measures. How do we really measure burden beyond the kind of basic approach that generally we've got now? So thinking about childhood obesity, childhood tooth decay, both of those are big issues where I work in a very deprived area. How do we safeguarding, all of those sort of things? How do we capture this and understand that kind of whole picture and the context in which people are working? So I think it's balancing on multiple levels.
Brilliant. John?
Yeah, Bimal has said, is there backfill for taking up one of the tiered supports? I think you covered that further down.
Yes, so there is no specific additional funding attached to the improvement programme, but I went through the different pots of money and what other pots of money are there as part of the kind of complete picture. And I think then if practices need additional support, then that's a conversation to have with their ICB about what other resources can be provided.
Yeah.
Miriam.
Sorry, I was just going to ask a question because about the technology, because you sort of alluded to technology, and I completely agree with you. It's an enabler to all of this. So if practices need additional technology, how to support some of these changes, how do they go about that, or where is there a pot for that? Is that just through a normal procurement channel?
So it's through the ICB. So that money is through the ICB. So ICBs will be having conversations with their practices about the move from analog to digital telephony, and engaging with their practices in terms of what they need from their digital bundle, that online messaging, appointment booking bundle. I think our research should hopefully help some of those conversations as well. So we really start to think about the value broader than monetary terms. So what's the value it has on how we work and how our patients interact with the service? And really, you know, I've talked about this before, and I talked about it when we talked about the websites. It's, you know, how we particularly work with our commercial partners, because they're not suppliers, they're partners. We can't do this without them. You know, improve the usability and the accessibility of tools from a patient perspective, and then get that functionality right from a practice perspective. And that is, again, a journey of continuous improvement. But the new framework will be published, and there will be an uplift to the GPIT funding that ICBs receive, and then they will engage with practices locally on what their needs are.
One or two more here. I know you've got to go on a hard deadline, so how much more time have we got?
Can we go until 6, Minal, and then?
Yeah.
Brilliant, and then we need to stop then so you can get away. Brilliant, thank you.
One word answers then, I think. VJ says, for practices who have adopted the model, what has been the most successful factors in delivering these initiatives?
Quite simply, what you put in is what you get out. So the more you involve your whole team, you involve the key decision makers, so both, you know, practice managers and key clinicians, and, you know, I guess the effort that the improvement work involves, then the bigger the impact you see. And that is as simple as it is.
Chris has said, how much capacity do community pharmacies have? And I would ask, how many of them are actually signed up to this?
So it's a difficult question to answer with regards to capacity, but there's lots of work that my community pharmacy colleagues are doing with the profession, and they are very positive about the plan and expanding clinical services. And I think this has given them almost kind of the policy needed to help them build some of that capacity. I think it's also really interesting to note that by 2026, all clinical pharmacists, as they graduate, will be prescribing pharmacists as well. So that really then opens up, you know, lots of doors in terms of the scope of what clinical pharmacy can provide. But there is ongoing kind of negotiation and discussion happening with the pharmacy sector through my pharmacy colleagues.
Thank you. Harry Longman, who may have an interest in this, says you showed a data set from Ask My GP data from 2021. Is there an updated set from GPIP intervention practices since then? He's wondering what the difference might be.
So, hi, Harry. Well, the general practice improvement practices, the first cohort is still going. They've not finished, so I can't say. They're in the middle of the program, so we've not finished the first cohort yet.
That's good.
All right, so I think, should we start thinking about wrapping it up so that Minal can get away? Because I know she's got an appointment she's got to get to, a very important one. So can I just thank you yet again for taking part and sharing all of this, because this has been really, really helpful. And hopefully everybody will agree with that. There will be a recording available, and we'll send out your slides as well. And if people don't mind, I'll also send out the slides that I had hoped to present right at the beginning of this, telling you a little about what the primary healthcare specialist group is about, because we're all about making IT good for primary care. So some of the things you were saying about IT being an enabler is just so important to us. So yeah, so we'll do that, and I'll just thank you again, and hopefully we'll see you again soon. Thank you all for coming, and we'll send this the details out in the next week or so, I believe, by the time this is edited. So thanks again, Minal. Have a good evening, and the same to everybody else as well. And thanks to VJ and John for support as well as part of this.